Yes, it's on YouTube now.
Oh, I better behave.
I mean, if that's what will work, because I've done everything, you know, I've tried.
Oh, I better behave.
Okay. Anyway, so if that's what will work, because I've done everything, you know, I've tried.
Oh, I better behave.
Yes. Okay. Anyway, so if that's what will work, because I've done everything, you know, I've tried. Yes. Okay, so we're going to let everybody in. And the YouTube is giving us some type of an echo.
Yeah.
So you have to turn it off. Who has the YouTube on? Maybe turn it off.
Yeah, I'll turn the mute. I'll mute. Yeah, that will work. Okay. So we are live on YouTube, and I'm going to let everybody in. We started recording. I'm going to count down to 5, and then I'll hit broadcast. So 5, 4, 3, 2, 1, 0. Okay. So we're going to see people coming in. We'll give them a little bit of time to join us. Dr. Ade, you're on mute.
Yeah, okay, yeah. Yeah, I can hear you guys now.
Okay. Very good. Okay, well, good evening. Thank you for joining us for another edition of Ghana Physicians and Surgeons Foundation weekly webinar. My name is Dr. Beth Asewa. I am an infectious disease physician, and I've been a moderator for these events for the last few weeks, and we're excited to have you join us. Today, we have a very exciting lineup for you. We're going to be talking about the heart and cardiovascular complications of COVID-19. This is an area where people have wondered. We've all heard about heart disease being an underlying condition for a severe disease in COVID-19. Why is that? What is the spectrum of illness in heart disease? And what is the experience from a Ghanaian perspective? And so you will be hearing about that. Ghana Physicians and Surgeons Foundation of North America is a non-profit organization that was formed in 2002. It's made of a group of physicians who are dedicated and committed to helping with the public health of Ghana, and also ensuring that the medical education of Ghanaian students, residents, and fellows, we contribute to it as much as we can, and we work in very close collaboration with the Ghana College of Physicians and Surgeons. And so today it is my pleasure to have one of the physicians who is a member of the Ghana College of Physicians addressing us today. And with me is Dr. Paula J., an infectious disease physician who was on the panel just about 2 weeks ago to introduce Dr. Akama. So thank you very much for joining us, Dr. J.
Hi, welcome everybody. It's my pleasure to actually it's a privilege to introduce Dr. Joseph Akama, who is the immediate past head of cardiology at the University of Ghana Medical School. Dr. Akama returned to Ghana in 2013 after 17 years of training and working in the United States of America. He's an experienced physician with multiple board certifications in internal medicine and cardiology, including interventional cardiology, nuclear cardiology, echocardiography, and vascular medicine. And he topped it up recently by earning an executive MBA degree at the University of Ghana Business School in entrepreneurial management. He's a faculty member for the American College of Cardiology and has served as a faculty for the Ghana College of Physicians since 2013. He's a consultant physician and an interventional cardiologist at both the University of Ghana Medical School and the Kolebu Teaching Hospital. He's also a voluntary lecturer and consultant physician at the University of Development Studies, Medicine and Therapeutics Department in Tamale. And Dr. Akama is passionate and enthusiastic about building capacity in Ghana. And his areas of interest include expansion of resuscitation programs across Ghana and West Africa, and a reduction in the cost for invasive management of both acute and chronic coronary syndromes, peripheral artery interventions, and pacemaker implantations through capacity building and advocacy. And actually, he's been working hard in that regard, partnering with his partners in the USA to help train cardiologists, cardiac nurses, critical care nurses, EMS staff, ECG technicians, as well as outreach cardiac clinics for children and underserved women. So Dr. Akama has been part of the build-up in Ghana, and we welcome him today for a very interesting discussion. Welcome, Dr. Akama.
Thank you. Good evening, and I wanted to thank the Ghana Foundation in North America for giving the opportunity, and also to acknowledge all the hardworking physicians in Ghana who are frontline or sideline or whatever you want to call yourself, working so hard, both at Kolebu Teaching Hospital, the Department of Medicine. Kudos to you, Dr. J, and now Dr. Palu has taken over. We really are grateful for the leadership. Also at the East Medical Center and UGMC, where things have been done, even with the limited resources. So without much ado, let me go ahead and pose the questions they sent to me. Actually, we're supposed to be two presenters, but I will try to cover as much as possible. If we get other cardiologists joined in, they can answer some questions. So please share your personal experience of cardiac complications of COVID-19. Discuss the role of hypertension, congestive heart failure, coronary artery disease, and arrhythmias as risk factors for COVID-19. How safe are ACE inhibitors in COVID-19? What is our false negative rate in Ghana? How many patients declared recovered have cardiovascular diseases or comorbidities? Among the dead, how many have cardiovascular diseases? The last three is bolded. I wouldn't try to answer those. Somebody can answer them if they can. So we will try and review consequences of SARS-CoV-2 infection and cardiovascular system. I'll review safety of ACE inhibitors, ARBs in COVID-19 patients, list cardiovascular complications of SARS-CoV-2 infections, and then discuss management of COVID, CVD in COVID-19 era in Ghana. So the impact on our patients in Ghana has been enormous, okay? High risk of morbidity and mortality with co-infection with SARS-CoV-2, fear of stigmatization. It is big time in Ghana, really big. Stigmatization is really a problem. So most of them don't want to come to the hospital, but they fear that they'll be listed as COVID-19. And we do that. Doctors, as soon as they come with shortness of breath, rule him out. And that is really traumatizing to the patient. So they present late or they don't show up at all and die. Fear of contracting COVID-19, okay, lack of access, reduced number of doctors and nurses because they have been pooled to take care of COVID-19 patients. Example, my buddy and close compadre, Dr. Owu. Dr. Owu is no more in Kolebu. He's heavily into COVID-19. When we need him in Kolebu, he's nowhere to be found. So such a person is needed for ICU care, but he's heavily dedicated to the care of COVID-19, and he's doing a tremendous job. Elective tests not available, lockdown syndrome, people develop DVT, PE, depression, weight gain, worsened non-communicable diseases. So what has been the epidemiology? So, and they announced that we had some 2 or so cases. And then the privileged contacts gave it to their people, they contacted. And now, at that time, nobody wanted to say, I'm coming back from UK. At first, it used to be a pride. No, I just landed. Nobody wanted to say it again because when you land, we would put you in quarantine. So people were hiding, and that made the problem worse. And now we're dealing with a widespread community problem, especially in the metropolis, Accra, Kumasi, where people are behaving as if there's nothing going on, really to the detriment of the spread of the disease. Ghana Health Service says we currently have 1,906 active cases and 223 are dead from COVID-19 in the document. So what are the cases? We have confirmed cases, a person with laboratory confirmation of SARS infection, irrespective of clinical signs and symptoms. We have probable cases, a suspected case for who testing for SARS-CoV-2 virus is inconclusive, or B, a suspected case for who testing could not be performed for any reason. And then you have suspected cases, a patient with fever or some symptoms. We have a lot of those. They have negative cases. So in Ghana, we haven't, that is my opinion, I may be challenged, but we have a lot of probable cases, okay? The signs and symptoms are there, everything is clear, feely, like we used to say, but the test comes back negative. So what do you do? So this is an example of such a case. This is a diabetic who came from Bulgaria to see me, and very close relationship of mine, peace. So she came with non-specific, just similar to COVID, diabetes and bodily aches, shortness of breath. We tested her, it came back negative. Just 5 days later, this chest X-ray was taken when she came in hypoxic. What else could it be? Okay, on the right side is her CT scan. And so the question was, what should we do? So we moved her to the isolation area for treatment, and unfortunately, she was overcome by her condition. Okay, she was overcome by her condition. Her son developed similar symptoms. And this is his X-ray. He refused to be tested. We tried to engage him, he refused. So we managed him outpatient. And that is his X-ray. He's recovered. He went for the mother's funeral. He's happy and lucky going. So these are the challenges we're having. So this patient, what do you classify them? A test was negative. They even repeated a test in the mortuary. It was negative. Anyway, so sorry for the crowded slide, but this is what I found from the Ghana Health Service site. You know, they give us piecemeal cases. I found this one from somewhere on the left side, case 1 to 28, okay, the conditions the patient suffered from and then died from COVID. And then you have 39, there's omission from 28 to 39, I don't know where the cases are. Then you have another omission between, I think that's next page. So this one seems to be going well from 39 all the way to 66, seems to be accounted for. But as we go higher, from 67 to 70, there's a gap between 70 and 96. And there's also a gap between 103 and 123. But what I'm trying to show here is the type of patients we had who died from COVID-19. May they rest in peace. But this gives us the chance to see the comorbidities. Unfortunately, some cases were listed as unknown. In the middle here, they're unknown, unknown, unknown. So when that happens, you don't know whether the physicians didn't have an idea of the case or died before they could take a good history, or the family refused to talk. Okay. So in the pattern that will get the data, sometimes you scratch your head, but this is from Ghana Health Service. Figure 4, percentage of COVID-19 cases by travel history. Ghana, March to April 2020. This is the first update, said history of travel, 23%. No history of travel, 77%. And they revised it. They revised it and came back and said, known history of travel, 18%. Travel history not yet established. Give me a break. The person doesn't know that he went to England or he went to America, but it's possible because, you know, people started hiding their identity because they didn't want to tell whether they traveled or not. But this is really some of the inconsistencies that we see from the data that we have to really think about. The problem with SARS-CoV-2 is the fact that it affects the cardiovascular system in a bidirectional way. There's an interaction between SARS-CoV-2 and the cardiovascular system in a bidirectional way. Why? It's because of the renin-angiotensin aldosterone system, where we have the actors that lead to hypertension. So mainly angiotensin II is a very potent hypertensive agent. It causes it's a hypertensive agent. It causes vasoconstriction, pro-inflammatory mediation, pro-fibrotic mediation, pro-thrombotic, and then arrhythmogenic in nature. So when that happens, if you block it, you'll be able to control hypertension. Okay. Along the line, the body also has an enzyme called ACE2 enzyme. So ACE2 enzyme is able to break down angiotensin II to angiotensin 1,7. And then through the MAS receptor, angiotensin 1,7 is able to give the body good things like vasodilation, anti-proliferation, anti-inflammation, anti-fibrotic activities, and then anti-thrombotic. Now, what happens is the SARS-CoV-2 uses ACE2. Okay, so ACE2 is a multifunctional protein. Its primary physiological role is the enzymatic conversion of angiotensin II to angiotensin 1,7 and angiotensin 1 to angiotensin 1,9, which are cardiovascular protective peptides. So angiotensin II is widely expressed in everywhere. So it is ubiquitous in the body. So when the virus gets into the system, depending on the route of accessing the person either by injection or through the nares, then it can influence proliferation of the virus and then infection ensues. So the person can have multi-organ dysfunction from the virus because all of these organs have it, okay? Nasal mucosa, the lung, heart, kidney, the brain, and Dr. J mentioned, talked about the effect of this on the brain. We also discussed locally the renal problems associated with COVID-2, SARS-CoV-2 infections. So this is why, in part, the array of systemic involvement of COVID-19 disease, okay? The MAS is a glycogen, a G protein coupled receptor through which angiotensin 1,7 signals. So it's very important that we understand this pathology, okay? The pathophysiology is a normal physiological process, but when this is depleted, then we think that there's a problem down the line. So how does ACE inhibitor and ARB work? The ACE inhibitors will inhibit conversion of angiotensin 1 to angiotensin 2. But even if you do that, you block the good aspects of angiotensin, angiotensin 2 receptor. Angiotensin 2 receptor has some good effects. Angiotensin 1 receptor has bad effects. So they came out with the ARBs, which would selectively block the angiotensin 1 receptor, which has direct effect on the kidneys, the heart, the vessels, okay? When it does that, then you're going to have vasoconstriction, vascular hypertrophy, endothelial dysfunction, atherosclerosis. And in the heart, it gives LVH, fibrosis, remodeling, apoptosis. And in the kidney, it decreases GFR. And so when you're able to block it, you get all of this benefit. Hence, the problem is, what should we do? So if you block ACE inhibitors, you also block the good aspect of the angiotensin 1 receptor. Okay, whereas if you block with ERB, it blocks only angiotensin 1, which is the bad one, and then you have the angiotensin 2 receptor, which is the good one, which helps with the good aspects together with the angiotensin 1/7. So this is a caricature showing you the effect of COVID-19 virus. Okay, so the SARS-CoV-2 virus, when it gets into the body, it attaches to ACE2 to be able to get into the cell and then replicate. When it does that, then you downregulate the ACE inhibitor, ACE2 enzyme. By downregulating ACE2 enzyme, then you give chance to the angiotensin 2 to be present and cause problems. And that is why locally there's vasoconstriction in the lungs. They've documented that, and then leading to ischemia, and then the pathology ensues in the lung. Similarly, it happens in various organs that have this mechanism. But if the ACE2 enzyme were to be present, then you're going to enhance angiotensin 1/7, and you have the vasodilation, anti-apoptotic mediation, anti-fibrosis, and anti-proliferation. And then you decrease the blood pressure, you have decreased fibrosis, you have the beneficial aspects of the RAS system. So what are the postulator mechanisms for cardiovascular disease involvement by the SARS-CoV-2 virus? So there's documentation that electro micrograms have shown the virus particles, and various studies have shown that directly the virus can infect the myocardium. Okay. 2, systemic inflammation, a so-called cytokine storm. When that happens, it causes a lot of problems, like a volcanic eruption. And then you have altered myocardial demand supply ratio. Acute respiratory illness can impair myocardial oxygen demand supply relationship and lead to acute myocardial injury. And then you have the pro-inflammation that leads to plaque rupture and coronary thrombosis, also enhanced by the fact that the person is thrombogenic. So adverse effects of various therapies that we give to the patients can cause problems. Okay? And then to make matters worse, they have electrolyte imbalances, fluid imbalances. And so the SARS-CoV-2 virus is really not a friend for the cardiovascular system. This is from one of our Ghanaian professors in New York, Professor Imoro Salifu, my buddy and classmate. He sent me this article of theirs explaining the effect on the cardiovascular system. And basically, it replicates what I just showed you earlier. So if you have ACE2 enzyme not available, then you're going to have to miss all of this, okay? And then the person will become hypertensive, will have hyperthrombosis, and so on and so forth. And when the virus gets into the body, it causes quite a lot of problems and leads to the cytokine storm, which has deleterious effects and thrombogenesis. And the patients are really, really thrombogenic. I had a patient who had pericarditis. We thought it was non-STEMI. We took him to the cath lab, and boy, he clotted so much. So, and I saw it with my own eyes, as we say, feely, with no heparin, he was clotting. So I had to give him heparin just for the diagnosis, which I normally don't do. Some people do, but my diagnostic testing takes a short period. But this guy, I had to give him 10,000 units of heparin to be able to finish the study. So it is not an easy problem, especially thrombogenesis. So the cytokine storm leads to a lot of problems. Plaque instability, interleukin-6 is going to be released. And so if we can inhibit interleukin-6, maybe the person will feel better. Okay, the cytokine storm can also injure the heart. The virus can injure the heart directly, will lead to myocarditis. And then all the above can lead to arrhythmias. Okay, so when you check the patient, most of them have increased cardiac enzymes. These are the 4 tests we normally do in Ghana if the person has money to do them. Okay, then we throw in CRP and ESR and we're done. So when they're high, what else could it be? Okay, in this era, but we can still have other viruses and other infections. So hypertension and COVID-19 is a complex relationship. Okay, it's a complex relationship. Hypertension and ACE inhibitors, ARBs. In Ghana, we define hypertension as 140/90. Recently, I was so happy, Professor Inkum, head of medicine at Kumasi, emphasized that we need to drop down to the American style and drop it down to 130/80, which I have been using. It's not because of my background, but I think we have to really be serious with Ghanaian patients so we can help our folks. So the Europeans still hang around 140/90, but they give you a caveat that if you're between 130 and 139, 80 to 89, they will treat you if you're high risk, okay? The Americans just cut to the chase and say, look, if you're more than 139, we'll take you serious, and we might not give you medicine, but we'll take you serious, okay? The prevalence of hypertension in Ghana is very variable, but reports go up to 60% of adults. In the USA, we don't have data on Ghana about this, but 63% of adults over the age of 16 years have hypertension. 50% of patients with hypertension are usually on ACE inhibitors, collectively called RAS. The inhibitors, RAS inhibitors, they are among the most frequently prescribed antihypertensive. In Ghana, you'll be surprised, we use a lot. And I'm really happy when I see patients being referred to me because they're on guideline medication. Sometimes the doses are small, but they have all the medicines dotted across. In my practice, this is a skewed information, so don't think too much. It's a cardiology practice. So obviously we see high-risk patients. So quite a number are on ARB or ACE inhibitors. There's higher rates of hypertension among severely ill hospitalized COVID-19 patients in Wuhan, Lombardy, and New York. Okay, this has been documented. Severity of COVID-19 in illness is skewed towards the elderly population who have a high prevalence of hypertension. So what happened? Is it because they're old and they got a COVID-19? Is it because they're obese? They don't exercise. They're deconditioned. So COVID-19 kills them, but they also have hypertension. Or is it because they have hypertension that made them have the COVID-19? That is really the big debate, okay? So when they analyze these studies, they found out that quite a lot of patients have hypertension, okay? Quite a lot of people have hypertension, especially in the US. So in the middle here, you have hypertension, the range of hypertension, quite a lot. So in Ghana, we will know a little bit in my table again, sort of about the crowded nature, but you can add, okay? You can add, see, count hypertension, and then diabetes, hypertension, diabetes, cardiovascular disease, including hypertension, none. So you can do that, and then you find out. But one would have thought that when they do their monthly update, they give us the whole gamut, so that we know what we're dealing with. But I had to tease it out, and you don't have all of it. So there's a lot of missing data. I didn't get all of it. Maybe somebody can look and see. But I counted only 121 cases, okay? And out of the 121 cases, 57 of them were hypertensive, okay? And quite a number had unknown comorbidities. So for instance, in this summary from case 183 to 191, you have unknown, and then you have renal impairment, kidney injury, diabetes, unknown, hypertension, unknown, preeclampsia, and then none. Okay, well, if I add a preeclampsia, I think I omitted a preeclampsia, then you have 58 patients out of 121. All right, So what is the bidirectional interaction I was talking about? So if you have hypertension, coronary artery disease, diabetes, you are susceptible to COVID-19, okay? And the severity can be high. And because of the way the pronouncements were made, a lot of patients became petrified in Ghana. I have a patient in Winnipeg, a professor, who was so afraid to come out because anytime she listened to the news, the information was that only people with hypertension and heart disease are dying. That's not true. Okay, that's not true. We have taken care of patients who have severe comorbidities and they've survived. They've survived quite a lot. I have about 4 patients who pre-COVID EFs were less than 20%, and they are walking around with post-COVID problems. So the COVID-19, when it gets into the system, can injure the myocardium directly, or through the systemic inflammation will cause problems, okay? QT prolongation, VF, VTAC, atrial fibrillation, and then thromboembolism. And then the drugs you give them can also cause problems. So it's a myriad of problems. So there is a recent article I encourage you to read about the ARBs and their use in Lombardy, I mean in the Italian Lombardy area. 6,272 cases were matched with 30,000 cases about the same age. The average age was about the same. What they found was that in this large study, the use of ACE inhibitors and ARBs was more frequent among patients with COVID-19 than among control because of their high prevalence of cardiovascular diseases. However, there was no evidence that ACE inhibitors or ARBs affected the risk of COVID-19. So I just cut the table short. If you look at it, so these are also unadjusted odds ratio, adjusted odds ratio, and they're about the same. If you compare beta blockers and ARBs, it's about the same. Okay, it's about the same. So there is not really a big fuss about which is leading to SARS-CoV-2 infections. So what is the bottom line of ACE inhibitor? There's no clear evidence that using angiotensin converting enzyme inhibitors or angiotensin blockers lead to upregulation of ACE2 in human tissues. Indicated in all patients with myocarditis unless contraindicated for other reasons. Standard doses recommended based on response, and standard precautions must be followed. So use them, do not omit them. Do not omit them. How about stroke? We've done with hypertension, the ARBs. How about stroke? Professor Safo, prolific writer from Kumasi, just released this. It's hot. I posted it in most of the WhatsApp pages. Comparison of stroke admission between January and June 2019 and 2020. And he and his team found that it's higher. It's higher. So stroke occurrence is higher. I was hoping he'll put in hypertension, then I would have been really happy, but he omitted it. Maybe he's going to come out with hypertension, another paper. But how about arrhythmias? We've encountered these, okay? We've encountered these. And the people in the UGMC, GAIS, and Kolebu, ICU, and even the observation they have will tell you premature atrial contractions, supraventricular tachycardia, atrial fibrillation, atrial flutter, first and second degree AV block. All kinds of stuff can happen in COVID-19 hearts, okay? It's because of the nature of the infection that attacks the myocardium, attacks the pericardium, okay? So you can have all of these. Potential mechanism, cardiac arrest. Oh yeah, that happens a lot. Cardiac arrest happens a lot. We were on rounds, we were called to see a patient who had SC elevation MI, and right in front of us, he decided to die. So this happens a lot. So COVID-19, and unfortunately, we didn't get a test result from that patient, but he had everything that indicated he had COVID-19 clinically. What are the mechanisms? Hypoxia, myocarditis, abnormal. We had a lengthy discussion of myocardial involvement in this area with the residents. And we found that arrhythmias can occur, abnormal host immune response, myocardial injury, myocardial strain, electrolyte derangements, intravascular volume imbalances, and drug side effects. When you have a patient who has SARS-CoV-2 infection, it can lead to a lot of problems. Some of them come and they're fine. Okay, some of them come and they're fine. They just had anosmia and that was it, they recover. But some of them go into challenge, palpitations, chest pain, and stuff like that. So in the lungs, you can have acute respiratory failure that leads to hypoxia, and hypoxia will cause damage to the heart. In the heart, direct injury by the virus or the cytokine storm can lead to myocarditis, pericarditis, and then we have the vascular problems. Both the veins and the arteries have increased thrombogenicity. Then you have the abnormal host response where you have an overreactive interleukin-6 outburst leading to the cytokine storm. GI, you have diarrhea. Actually, people have hepatitis. I've had 2 patients who liver enzymes were very high, they were vomiting, and then all the tests came back negative for COVID-19. But the inflammatory markers were high, okay, were very, very high. Okay, so what is that? Anyway, acute kidney injury. So let me show you some arrhythmias in Ghana. This is a gentleman who I saw at the University of Ghana Medical Center. Admitted him the very day I saw him because of high risk findings. And if you look closely, he's out of sync. His P waves are way off. Okay, so I don't think you can see. I don't maybe move this a little bit. Move this down. Okay, look at V1, and this will be a very prolonged PR. Okay, if you're going to call it a PR, prolonged PR, first degree, that'll be Guinness record for PR prolongation. Then you have, he had various ECGs. Similarly, okay, so the PR is getting a little bit shorter, but there's a lot of variation. Okay, there's a lot of variation. So here he's a little bit narrow, then he widens up, then a little bit narrow. So it's all over the map. This was a recent picture after he recovered. He still has the effect. Okay, his biomarkers are down, but he still has that accelerated junctional rhythm. That's what we thought. At one point, we thought he was in complete heart block. So this is from a COVID patient. Okay, this is from a COVID patient. 2 elderly patients, I'm told one of them was tested negative, but this was the ECG palpitations. They called us to see. She had an underlying condition. You can see that the ECGs are really eye-popping. This is a patient with hypertrophic cardiomyopathy. And if you look at the previous ECG, he has irregular pulse, and then suddenly he goes very fast, she goes very fast, and we can't see the P waves. Here in lead V1, you can see P wave, maybe P wave, then you can't see them. So this is an arrhythmia. This is another one sent to me from Antakradi. We manage over the phone, patient is doing very well, and you can see the irregular nature of the rhythm. Sometimes I think maybe she goes into a short run of atrial fibrillation and then goes back to her normal self. How about QT in COVID-19? Is a problem. We have iatrogenic problems. People are insisting on hydroxychloroquine, azithromycin. Fortunately, we at the Department of Medicine, we decided to use mostly doxycycline. Occasionally, I'll use azithromycin for a younger patient, but we mostly use doxycycline and ceftriaxone. But you can see the effect of azithromycin, decreased heart rate, increased PR interval, increased pre-QT interval. And then it has a drug-to-drug interaction. severe with amiodarone, the cyperamide, the fortilide, and then profophenone. And then if you give them beta blockers too, they will have problems. So you have to be careful. Hydroxychloroquine, the battle is still going on, but whatever it is, it causes problem. The heart rate is low, increased PR, increased QT, and then there's drug interaction. Okay, if we give antiviral agents, okay, which we don't have too much of in Ghana, but it can also cause some problems. Okay, the common one that has been published doesn't have any known effects yet. So we'll be collecting the data. I'm pretty sure they'll be publishing the side effects soon. And then we have to some extent, I think some pharmacies are selling tocilizumab in Ghana, very, very expensive. But you can think about this medication as one that doesn't cause too much interaction, ECG changes, but there's some drug interaction. So if the person has QT prolongation, he can go into torsades and then he may die, okay? So how do you manage them? You withdraw the agent, correct electrolytes, give them magnesium, and hopefully you get them out of the woods. How about chest pain in COVID-19 patients? A lot of patients come with chest pain, a lot. They don't come with fever. They do not come with fever. We rarely see patients with fever. So that temperature check is really erroneous, and most of the time, because they come with chest pain palpitations, and then maybe hypoxia. They're a bit tachycardic. Sometimes the blood pressure is low, sometimes it's high. And I've also noticed that they have hikes in blood pressure. Could be low, could be high. The sugar can go all the way up and down. When you see those rapidly changing things, think about COVID. But chest pain can be due to ACS, unstable angina, non-STEMI, STEMI, pericarditis, PE. So PE is like very common these days. So we've diagnosed so many patients with PE in the last 3 months, unbelievable. Then, so a survey which I took part in, conducted by the European Society of Cardiology, I wanted to find out the effect on STEMI by COVID-19. And the survey revealed that one of the main consequences of the pandemic was that fewer severe heart attacks patients went to hospitals, and that this phenomenon affected many hospitals. 78% of respondents perceived a decrease in the number of STEMI patients. According to them, the number of patients admitted to hospital had decreased by 50%. Now it's beginning to go up, okay? We used to fear, now we don't fear. We will fight it with all our might. So we are getting more patients coming in. People are becoming bolder. Many healthcare professionals also noted that STEMI patients who presented to hospital did so late. So this is a problem. And the survey was multinational, really multinational. Africa was included. That's a good thing. Anyway, how has the pandemic affected cardiovascular care in Ghana, interventions especially? We only have 4 cardiac catheterization laboratories. Okay, one in Kumasi, one in Kolebu, one in Osu, it's a private entity owned by Dr. Neglate, and then one at Urake. These are the only 4. And when the pandemic happened, I'm not sure about Kumasi, but Kolebu, we had to close it down. And then we had to close Anaglate's place down. But Urake was the only operating center, and they had increased numbers of patients. They had increased numbers of patients with ACS within that short period. And also, the ACS patients are usually confused with pericarditis, with myocarditis. So it's a big problem. And sometimes it is true, the COVID patient might have ST elevation MI. So we are really in a dilemma. Patients with SARS-CoV-2 positive, if they have it, what do you do? If they're very sick, my doctrine is that if the person is very, very sick on life support and shows ST elevation MI, concentrate on managing the patient, okay? Especially if you spend their last money in the cath lab and they don't survive, that's a bummer, okay? So I think we need to really come up with a plan, but it's not a consensus decision. That is my thinking. But if the person is okay, he's up and about, has ST elevation, even if the test is positive, we can still go ahead with high risk precaution, just like some of these patients. So this is an abbreviated list of cases that were done in the facility that was open at Uracare. Instead of some of the patients were delayed, some of them had COVID. So the increased rate of ACS is not something that is out of textbook. We saw it, okay, and we're still seeing it. People got delayed. I had a patient who had MI in April, an in-law of a doctor. We just finally put him on the list for angiogram last Wednesday by Dr. Dade and the team at the National Cardiothoracic Center. It is now open. So some of you who have patients who are waiting to have angiograms, please do not hesitate to send them to the National Cardiothoracic Center, or if they have capability, they can go to the other facilities, Uracare. This is an example of cases that the ECGs will see. This 53-year-old Nigerian banker with a large anteroseptal MI, and then the 85-year-old patient of my buddy, Dr. Boima, who gave us really challenges, but we unfortunately we lost them, both of them. The Nigerian was successfully intervened, but he died about 2 weeks later. The 85-year-old man went into shock and really bad, and we couldn't bring him back. So we had to be realistic. We had to be realistic. This slide, I like it in that it gives you 3 options, okay? One, is the patient capable? Is he capable? If he's capable and he's okay, he's not very sick, and he's not hypoxic, he's not really dying, then you can think about angiogram, arrange for angiography, and there's high risk precautions. So there's double precaution. So you have the mask, and at the same time, we do the eye protection. So it is done at the National Cardiothoracic Center, and then also I will show you some examples and conclude so we can have some questions and answers. This is a 53-year-old Caucasian who presents with chest pain. The ECG, if you look closely, not really remarkable, but you have this non-specific T waves, but the biomarkers were elevated. This is angiogram, and if you look closely, there's a missing vessel in the middle, okay? There's the one at the top going to 2 o'clock is LAD, the one coming down is circumflex, and there is a missing vessel. It's an island of no blood supply. So there's a missing vessel, and then you can see that the staining of contrast. So this is a ramus intermedius, which was successfully intervened on. That's the wire going through the middle into the vessel, and then balloon, the vessel is open, and then stented, okay? So this was done, and you see before and after. Now you have 3 vessels on the right, you have 2 vessels on the left. So this happened during this COVID period. And this is my patient who had an MI, unfortunate gentleman, and we noted that he had right coronary artery disease, but he got lost to follow up the cost of the procedure. He was able to do the MI, but the subsequent intervention, he defaulted. So we're just treating him medically. And we don't blame him because it's expensive. So fortunately for him, he started having chest pain with his caring wife present. So she bundled him and called me. I said, okay, bring him immediately. And you can see the ST elevation MI. And when they come, you're not sure whether it's COVID or not. Okay, so I always tell my trainees that everybody's COVID until proven otherwise. So when he came in, we were suspicious that he had COVID, but nevertheless, with high risk precaution, double precaution, we took an angiogram. He's tight, he has a clot right there. And then we intervened. his left system had patent stents. He still has some disease here and there, but the main culprit was the right coronary artery that supported the inferior wall MI. So PCI, the wire cross, then we put the stent, looks okay. This is a case, gentleman, really good gentleman, a CEO who came in with chest pain, and then his doctor did an ECG and called me immediately, and the ECG was eye-popping. You can see that there is a lot of ST elevation. Okay, but if you look closely, you see that there's PR depression. Okay, and the STs are all over the map. So, of course, we don't have time to think about it. Elsewhere, they have other tests they can do that will help. Okay, so in Ghana, we also have those tests. So this patient had all the 9 yards. He went through all the 9 yards. So we did this. He was still having chest pain, relentless despite our management. And then we took him into the cath lab. And then the coronaries did not have any ACS lesion. He had minor disease. And then we came out, sent him for MRI. And lo and behold, he had inferolateral myocarditis. So this is a local myocarditis. So myocarditis is not usually global. It can happen that it's a local effect. So this was his ECG. Down the line, he started having some arrhythmias. You can see, so arrhythmias can happen in COVID era. Unfortunately, his COVID test came back negative. Should we send him for another test? If I suggested, maybe he would slap me. Already, the man is praying that he shouldn't be COVID. Then I'm pushing him to test again. So it wouldn't be wise. But all his biomarkers were high. He has some mild disease in the right coronary artery. And then the left system also had some disease, non-obstructive. So we're managing medically. His ECG completely resolved. Okay. When he came to clinic, he was smiling, ECG back to normal. No Q waves. That's the beauty about myocarditis. They don't leave Q waves, as opposed to ST elevation MI. Okay. This is an example of the localized myocarditis I'm talking about. This credit to Dr. Harold Ete, the non-invasive specialist in charge of the MRI imager at Uracare. It's a young man who was sent to us for STEMI, but upon questioning him, we thought it was more myocarditis. But he had classic STEMI. The biomarkers were elevated. So we said, instead of sending him for angiogram, he's younger. I think he was about 20 something, I'm not sure. And lo and behold, he had myocarditis, no evidence of MI. So he was managed appropriately. How about other patients who had ST change? This person had diffuse ST elevation, similar to the old man. And you can see that there's PR depression. And so the story didn't fit. So we said, look, it's likely to be myocarditis. So we managed her as a myocarditis. She was referred from the polyclinic and she recovered. This is a gentleman, 90-year-old man we use for case discussion during the cardiology ground rounds. He came in. Unfortunately for him, he uses drugs. So we label him as a drug user who had MI from the drug. We didn't know what it was. We tried to find out. But look at his ECG. He has ST elevation in lead 1, ST elevation in lead 2, ST elevation in lead 3. The AVR is up and down. Then AVF, ST elevation. Then you have reciprocal changes in V1, V2. So when you have that, is it truly an MI or not? But he didn't have money, so we are stuck. Okay, so we do what we do in Ghana. We manage him, and I said, this is myocarditis, let's go ahead. We gave him anti-inflammatory agents, and then it got better, the chest pain got better, the STs are improving. Day 5 of admission, he went home, and he was supposed to come back and repeat the echo and ECG, he never showed up. So this is a classic case of myocarditis, young man. We didn't think that it was an MI. But if we had capability, we would have gone for MRI. and the MRI will confirm it that he had a localized. How about pulmonary embolism? This 74-year-old lady, hypertensive, syncope, palpitations, hypoxia. So when they call me, I say COVID. Okay, anytime you hear syncope, palpitations, hypoxia, COVID. And the ECG was sent to me. I said it's acute RBB. And if you look at it closely, you have S in one, you have some tiny Q in the tray and T wave in the tray, and they have acute RBB. So this patient went to test positive and was managed. He had atypical pneumonia and a thrombi on the scan. This is a very sad case of mine that came in. The first instance came with atypical pneumonia and pericarditis. Oh, the thing is not playing. Let me see. Okay, I didn't look it. Let me see whether to play. Okay. So I will have it, yes. Sorry about that. So you have pericardial effusion, and so it's circumferential. But we thought we were going to drain her, but after we started the anti-inflammatory agents, she got better. And then by day 5, the pericardial effusion was gone, and she was feeling better, okay? So subsequent management, the delay in diagnosing COVID, it took a long time for the test to come back. And so the long and short of it is that she came back, okay, with the saddle embolus. Okay, she came back with the saddle embolus. So this is a CTPA, this is a main pulmonary artery, and you have the saddle embolus across, almost occluding this one, and then halfway occluding the other one. So this is a very pathetic case. All right, so what my take on the management of ACS and other cardiovascular disease in COVID-19 pandemic era? We need specialists. Okay, there's no denying about it. We need cardiac specialists, we need cardiac nurse specialists, cardiac technicians, cardiac intensivists, and we need real intensivists, cardiac catheterization laboratories across the country, if we could, intensive care units, mechanical assist devices. So these are very expensive stuff. Okay? And we have to think about triaging the patients and maximizing our medical management. Okay? I haven't used, so one question would be, have you used any fibrinologic agent in STEMI for a COVID patient or STEMI patient? No, I haven't, because they're expensive. Okay, one dose of antiplase is 10,000 Ghana cedis. Okay, one vial is about 5,000, another vial is about 5,000. So 100 milligrams, that's 10,000. That's a lot of money. So I must as well just send her for angiogram or send him for angiogram if they can afford an extra cost. The future, my take on this cardiovascular disease problem with COVID is that we should seize the opportunity, and not just cardiovascular diseases. Everywhere we have to seize opportunity, realign the training programs, have a strategic plan for Ghana that in the next 10 years, one district, one internal medicine, one OB, one pediatrician, one surgeon, one district, period. Then when you go to a region, one cardiologist, one nephrologist, one neurologist, okay, then you have plenty of specialists. If we can achieve this, believe me, the healthcare problem in Ghana will be really taken care of. Now, the other super specialists can be left in the teaching hospital. But if we can get this in Ghana, let's extend it to 10 years. That would be really good. Nurses have to be trained, and we need sincere technicians who wouldn't galamsey. Okay, we have technicians who are galamseying every day, okay, and causing trouble. So we need sincere people. We train them, but don't go about galamseying. So negotiate with government to upgrade hospital equipment. Okay, the problem with procurement is pandemic in Ghana. It's really a pandemic. Okay, so collaborate with Ghanaian doctors like the US doctors, UK doctors, German doctors, to come and help. Okay, we have to have a role for them to come and play. Okay, So we have to really think forward. And I think I will end here. Sorry, I took too much time. Thank you very much.
Well, Dr. Akama, thank you so much. All I can say is wow, wow, wow. And you can stop your screen share so that we can see your face and then also hear. So thank you. This was an excellent presentation. And I think your last slide almost made us want to appoint you as the Minister of Health for Ghana, because it seems you have a vision for what the healthcare in Ghana should be like. And this was engaging, it was excellent, it was very professional. And if it was food, at least I feel very full right now with all the knowledge you've given us. So thank you for this amazing delivery. And I've done presentations, so I know that at a minimum, you spent at least 5 hours, 4 to 5 hours on this. So we want to thank you, first of all, for the wonderful presentation and the amount of time you went into digging data and making sure that you didn't serve us just a small meal, but you served the full course of everything that we needed to know. You touched on hypertension, arrhythmia, MI, pulmonary embolus, saddle embolus. Like, you really broke the topic down, and no wonder you're making such a difference in Ghana. And I think you're a shining example of somebody who came to live in the US for maybe 20 years or more, and in spite of all the barriers that were facing you, you pushed your way into Ghana, and you were determined that, look, I don't care the obstacles in my way, I'm going to stay and make a difference. And you have made your light shine, and you're shining it back into the US, and we're really, really appreciative. And we also want to thank everyone who took the time. I know it's about 11 p.m. in Ghana, so all the people from Ghana who are still on with us, we want to appreciate you, and also appreciate Dr. Akama too for his time. So we'll start off with some questions. The first question I have for you is, what is a galamsey technician?
Well, it's a colloquial. I'm sorry to have used that, but
Okay.
we have, the galamsey of gold and stuff.
Yeah.
So technicians will train, and they have their own ECG, and then sort of fall in line with the hospital plan. They will do their own thing on the side. But they are not really a big problem compared to other technicians like radiographers and stuff. They do all kinds of ultrasound, they read it, and you don't know what you're talking about, okay? And you have to repeat it. And so when you say, I'm going to repeat it, the patient get angry. I already had an ultrasound, but the ultrasound says your uterus is upside down. So what should I do? But I'm just giving, that's an extreme.
Okay.
But
I mean, it's good that we know the lingo, so it's good.
Yes,
and
yes. So we have these technicians who go out to build their own practice. Instead of falling in line, technicians have to work with physicians so that we can have a very good, streamlined patient care. That's what I meant by Galam.
All right, very good, very good. And so for all those who have joined us, you can either type your questions in the Q&A section, or you can type it in the chat box. So Dr. Paul J had a question. He wants to know, does SARS-CoV-2 cause direct myocardial injury like a viral myocarditis, as you can see in Coxsackie, enteroviruses, adenoviruses, etc.? Or is it all the indirect effects via the cytokine release?
Yeah, so there was a slide I omitted, but there've been studies, and there's a gentleman from, I'm not sure it's New York or somewhere, who documented, okay? He took the specimen, and then they were able to biopsy the patient, and it showed that the SARS-CoV-2 virus was indeed inside the myocardium. Okay, so there's a direct infection.
Direct, okay. And it's thought to be more of that than, the few cases of ischemia. So the next question is from Dr. Theresa Ruby Kwate Papafiu, and her question was, so far, what has been the success rate in terms of prognosis for those who present with myocarditis in Ghana? And then secondly, she wants to know if electrocardiogram should be routinely done for all suspected COVID-19 patients.
Yes, so we don't have the data yet. I'm pretty sure the Department of Medicine will be spewing out some data soon. But I'll tell you that all the cases I got involved who had myocarditis, we documented myocarditis, did well. Just maybe a handful, 2 or 3 died. Okay, and these are a lot of patients across the country. So I get calls from across the country. So give it to the physicians. Once we initiate the treatment and monitor the patient, they do very, very well. Dr. Free Mensah, acting chief of intensive care unit at Kolebu, together with us, where we work as a team, we've seen quite a lot of sick patients and who have, fortunately, we thank God, have come out. Some of them are big politicians, and they've come out and they have gone home to their families. And most of them had comorbidities. So it is not a very rare occurrence for them to recover. We've had some challenges with people who have bad pneumonia, hypoxia, and renal failure, and that is a bad combination. So, but by and large, the cardiac patients do very well. You throw in anti-inflammation, military agents, colchicine, and then they do a prednisolone or methylprednisolone, and they do very, very well.
Okay, very good. And her second question was, should every patient with a suspected COVID get an EKG?
I will advocate it, but not blindly. If the person is very young, there's no need, unless the person has some specific symptoms. But when the person hits middle age, okay, you have to, especially if you're considering using azithromycin in the ICU setting, definitely you have to do ECG, okay? Our medicine, where we do a lot of doxycycline and ceftriaxone, we still do ECGs, okay? So we can monitor them because they have electrolyte imbalances. Some of them also have palpitations, chest pain, so we need an ECG. But younger patients, very young patients, no cardiac symptoms, there's no point. But if they come with chest pain, like the 90-year-old, definitely he was having severe chest pain, so the ECG revealed the pathology. So you have to select the young ones.
Okay, and I'll just throw this in and let me know your thoughts. Like, so in the US, when almost everybody was getting hydroxychloroquine, they were doing baseline EKGs just because of the QT prolongation. And I've had patients who've had that happen. So in Ghana, where we still have hydroxychloroquine as the standard of care for COVID, would you recommend at least getting a baseline to monitor for QT prolongation if the EKG machine is sitting somewhere anyway?
Mm-hmm. Well, if the ECG machine is there, not locked under somebody's door, somebody's gone home and then it's locked it, and if they have the ECG machine to begin with, okay, so ECG, even though it's become more available compared to when we were in medical schools, all those yesteryears, these days ECG is very common. If private hospitals have ECGs, the problem is the interpretation. And so I would say if you're going to start somebody on hydroxychloroquine, azithromycin, or any medication, try and who has COVID, do an ECG. You'll be surprised what information you get. Okay, so, but if we enforce it when the ECG machine is not there, then it's a problem. We've had patients we think have COVID, but they can't afford CT scan. Okay, they can't. So what do? We manage them, and some of them do well. Okay, some of them come back walking and no more hypoxic. So,
Right.
These are really challenges that we deal with. But if you are capable of doing the ECG, it's good, you should do it.
Okay. So you have a lot of people saying kudos, congratulations, well done. Gina A said, great presentation, thank you. And Akogo Atia Philemon said, wow, doctor, great presentation. And Dr. Theresa Ruby Quote Papa Pio said, very wonderful presentation, thank you. And Indiagu Abu said, great presentation. Mariano Poku Ejakwa said, good job, Dr. Akama, always very exciting. And Dr. Amwa said, thank you, and very educative and instructive. And You must know this person, Dr. Lebene Fiakono. He said, awesome presentation, my boss. As usual,
Yes.
you keep it interesting. And Dr. Lipui is one of the GPSF members here in New York, said, excellent presentation. And also how inspirational to hear about the wonderful work you're doing back home. Bravo, thank you. And in that note, I also want to comment that Dr. Annette Anson is a pediatric cardiologist. She was one of the people who presented first for our webinar series. One of her lifelong visions is to build a pediatric cardiology center in Ghana. So maybe
we will help her.
Yeah, she said, wholeheartedly agree with you, Joseph, on the need to train more specialists and nurses, create a pipeline. We need to invest in ourselves. And so we need to continue ongoing collaborations abroad. And I also saw you had mentioned that every district should have a nephrologist. So just recently, the Ghana nephrologists and US nephrologists have been in a WhatsApp group because we had one of these focus on nephrology, and there's been a lot of talk on the group. So I think this will give room to a lot of collaboration. Thank you, Dr. Ansong, for your contribution. And Ndiago Abu said, in a short term, how could screening and quick referral of cardiac patients to specialists be integrated into the primary health care in this COVID-19 era?
So it's still in the pipeline, but most people have our WhatsApps. It's common. My WhatsApp is very common. People send ECGs across the country. But Dr. Doku, who is the current head of cardiology at the University of Ghana, has a program with Bayer and the German government. And once we roll it out, there's going to be a 24/7 call system where people can send in information, questions about medications for heart-related or cardiovascular-related patients. To give him a lot of credit, and the Ghana Health Service, Minister of Health, Ghana Health Service, and all the partners, there is a new cardiovascular guideline book for Ghana. Okay, so that is going to surpass the recommendations in the standard treatment guidelines. So we're hoping that they will incorporate this book straight into the Ghana standard treatment guideline for cardiovascular diseases. Okay, very, very comprehensive. So if you don't have a copy, please send me an email. My email is jakama@gmail.com, jakamah@gmail.com. I'll send you a copy. And once Dr. Doku gets this enrolled out, the whole of Ghana will not be suffering from doomsday when it comes to referral for cardiovascular diseases.
All right, okay. And to all of you who are on the panel or joined us, the presentation will be on YouTube. I've put the channel on here, the link, so that you can ask questions or review it again. And Dr. Dominic Akatiba and Charles Donkoban said, great presentation, great, Dr. Akama, God bless you. So there's a lot of blessings coming your way, Dr.
Thank you, amen, thank you.
People are very, very, very grateful.
Thank you.
People are very, very grateful. See here, I don't see any. Okay, so Georgette is in the UK. Okay, so first of all, Dr. Paul J had a question for you. He said, how do you balance the use of hydroxychloroquine as COVID-specific therapy in these COVID patients? Paul, you are here, so do you want to clarify your question? Because I don't even understand it.
So I think, so generally, there is a COVID-specific treatment, and then there's also the adjunctive treatment of whatever specific systemic disease they have. So in this case, the cardiac procedures and anticoagulation. So what do you use as COVID-specific therapy in these persons? Because I know the first line is hydroxychloroquine. So generally here they use remdesivir and dexamethasone in addition to all the adjunctive therapies of anticoagulation and MI treatment and
Well, I don't think it is the first line. It is a recommended by the latest guideline, which might change, as evidence is building. as we get more information, the guideline might change. But the current guidelines suggest that you can use it, or in place of that, we just give them the antibiotics, okay, without hydroxychloroquine. So I have not used hydroxychloroquine. Okay, I have not used hydroxychloroquine. I won't lie, and my patients have recovered. Okay, I use my typical outpatient dosing, and you can quote me anywhere. You can't tell me I'm wrong because we don't know COVID. Okay, so I'm doing what I think is good for the patient, and the patient have done very well. So a resident called me and said, "Why are we using so much high dose prednisolone?" And my reply was that we don't have the luxury of having interleukin 6 inhibitor. We don't. So I use high dose steroids at the beginning, then I taper down. And all the patients have done that. By day 5, their lungs are clearing, their energy is back, and they're doing well. Okay, so I use doxycycline, okay, and then prednisolone if it's an outpatient, or dexamethasone, okay, and then I add coamoxiclav, okay, or if they don't, they're allergic to penicillin, I use levofloxacin or Zinat, okay. So these are the combination. Then you have the various supportive therapy, and I'm telling you, one of my supportive therapies is neem leaf vapor inhalation. Okay, I don't know whether it's psychologically, but the patients feel better when they inhale the local therapy our great grandmothers and grandmothers used to use for fever. And they inhale, they get better, and they come back, and they're doing very well. So I have, as I was telling you, quite a lot of patients who have been treated outpatient. Why outpatient? The beds are not available. You call this hospital, we're not taking. This hospital, we're not taking COVID. This one, we're not taking. And you can't lie. You can't say that, oh, the person has pneumonia. I can't not lie. So I have to tell them, I suspect this patient has COVID. Oh, we're not taking. So Kolibo is full. Then what do? You put in your backyard? No, you have to send him home, advise him to stay at home. And most of them have done very well, outpatient management of COVID-19 in Ghana.
Excellent, excellent. And then Georgette Jabba she lives in the UK, and she's a non-medical person, but she has a question because she had a sibling who developed COVID-19 and is back in the hospital with a pulmonary embolus. She shared that last week with us on the webinar. She said in the UK, we're still being told that there is no treatment for coronavirus infection. Over 70 Ghanaian patients infected with coronavirus have died. What do you have to say to that? And before you answer that question, Ellen Zazi said, very beneficial. Thank you, Dr. Akama. Masha Jiman said, to be a doctor is wonderful, but to be a great teaching doctor is absolutely amazing. Thank you, Doctor. God bless you. And Alfred Topa said, thank you, Dr. Akama, for a great presentation. You've been a great blessing to us. You know, I don't know how much time you put into this, but you should have a good night's sleep tonight, because so many people are saying thank you, thank you, thank you. So Georgette's question, she said, what do you have to say to that? 70 people have died in...
Yes. So I will also defer to Paul. He's an infectious disease specialist, and any other person on board. I've seen Joe Comey, my buddy. He says, ha, 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 we use NIM. and he says he advocates for hydroxy for moderate to severe cases, and doxy and steroid. That's his combination. So everybody has his own do. And besides, to be honest with you, sometimes I feel if you just give attention to the patient, okay, to that patient, give them love, help them through the psychological trauma, they're going to pull through. That is don't quote me, but I'm thinking. But so it is true. I'll let Paul also answer that question. It's true that there's no treatment for COVID-19 that we know. Otherwise, the person will be so rich with all these infections. But I'll let Paul answer this in depth, and then we'll see. Paul.
So yes, you are right. There's no definitive treatment, and therapies are still being tried out and all that. So dexamethasone has been shown to have mortality benefits, as in when you give it to patients, they are less likely to die. Remdesivir has been shown to have morbidity benefits. If you give it to them, it shortens the duration of disease, but it doesn't prevent them from dying. It doesn't make it less likely for them to die. And then there's a lot of debates, like we know about hydroxychloroquine, the side effects. Is it worth the side effects to use it or not to use? And then there are other antibiotics too. So you are right, there's no definitive therapy other than dexamethasone that is likely to prevent people from dying. I guess that's the doctor.
Yeah. I agree with you. So the contributor from UK might be confused because we're advocating for some medications. These are all try and error. Okay. To be honest with you, they are similar to neem leaf. It's just that they have been tried. We haven't tried neem leaves. Okay. We haven't tried neem leaves. So we found out that people are using it and some people get better. Okay. But there's no specific treatment like HIV, where the specific treatment brings down the viral load, or hepatitis B, where the viral load will come down. With COVID-19, we just use supportive and some of these medications which have been shown to help. Okay. The unfortunate thing is the number of Ghanaians dying. We really sympathize with you, with your family member, and we wish them all the best and may they rest in peace. The problem is the comorbidities. Sometimes the comorbidities affect us a lot. People work so hard in the Western world, they hardly take care of themselves. So and then most of them are working menial jobs. So when they get infected, it can be really terrible. So they've suffered a lot, but we really sympathize with you, okay? But it's true that we do not have any treatment, but we use these medications because some of them help.
Right. But just to add to the conversation, Dr. Akama, I don't want people to go away, especially the non-medicals, thinking that it's just trial and error. But because if even though there's no COVID-specific treatment, like the patient you presented who came with either myocarditis or PE or pulmonary embolus, or you are going to treat the condition, because people have asked, okay, if there's no treatment and there's no cure, what is the hospital going to do for me? And it's important for people to know that even if you come in with shock and you are dying, there's a way of giving you fluids and pressor support. If you're in respiratory failure, you'll be put on a ventilator and so forth, right, Dr. Akama? So that people know that at least we will hold your body together till you stay alive, and then you pass over, the storm passes over, and then you can go home successfully, like a lot of Dr. Akama's patients, right?
Yes, yeah, very good. I agree with you. I agree with you.
Although, just as a joke, somebody has said, you know, the Russians have a vaccine out and there's absolutely no data on what if it's just water in the vaccine? I mean, how would we even know? Because with COVID-19, you could drink just water and you may be just fine, you know? I mean, unless you develop a complication that requires treatment. Anyway, let's go on. Cynthia Bremen said, is the risk of developing COVID-19 symptoms similar for all patients with a heart condition, or are there differences? I think she missed the first part of your talk, but it probably be good to answer that.
Well, the COVID-19 affects everybody. If you expose yourself, you're going to get it. There's no two ways about it. The problem is, what is the amount of virus that enters your body and how you respond to that virus? And Paul can expatiate on this. But there are people who get infection, but they do fine. They don't even have symptoms. They walk around and they spread it. If you don't wear your mask, you don't stay in the house, and you go party, you're going to come down with it. And we've had examples in Ghana where people went on trails and then they spread the infection. Okay? Paul, what do you think?
That's really, I don't have much to add to that. It's just like you said, we don't know why some people go on to manifest the disease and others do not. But like you said, the likelihood of you manifesting active disease is higher when you have underlying comorbidities, and then also when you are elderly, you know that. But again, there are people who remain completely asymptomatic And then there are those who eventually go on to manifest disease. And then there are grades of disease, like we say, mild disease, moderate disease, and then severe disease. Again, we don't know why people manifest the disease the way they do. So.
Right. And I think the closest they've come to trying to prognosticate to see who is going to develop severe disease is the blood group trial or retrospective study that they did and managed to locate some chromosome on some portion of chromosome 9 that they found that those with blood group A seem to have a slightly higher risk of developing severe disease versus blood group O. And it turns out that 67% of people in Africa have blood group O. And so maybe part of the reason why we're not manifesting severe disease, but it doesn't seem to answer it all. So at this point, we don't know who is going to, like a husband and wife, we don't know who, if they all get ill, one will get really worse and one would still be okay. So Dr. Obri said we have a mishmash of medication trials. Should we move away from the usual scientific way of our usual therapies, or why are folks like you not publishing in peer review forums? I'll let you answer, but I think you're busy taking care of COVID patients. So, I mean, I see like 6 publications out of what you presented, but I'm sure if your medical students will write it up for you. But Dr. Obri is asking why are you not publishing in peer review forums?
Yeah, so like I said, the Department of Medicine will be spewing out a number of articles from the work that has been done. Now, if you're a worker in the front line and you stay from morning till evening, the following day you go back morning till evening, it's not an excuse, but I'm telling you, you'll be so drained. You have so many ideas, so many. You collect the data, but you don't have time to sit down. Else, the workers have people who work for them, okay? Research assistants. Unfortunately, the Department of Medicine, we are not too enhanced to have research assistants. So if we could get a lot of research assistants to help, the number of data will be coming, not just COVID-19, a lot of work that has been done there. It's amazing. With the limited resources, with the time that I've been with Kolebu, it's amazing. People who recover from limited resources and stuff. People who are outside, you'll be looking for ICU. Or we throw them on the ward, and then they get out and walk home, okay? And that is the marvelous thing about putting yourself down and say, I don't have the resources, I don't have anything, let me just do whatever I can do to help the patient. So there's a lot to do, but I agree with you. But I don't understand your point about, should we move away from the usual scientific way? You know, there's been a doctrine, you can't change it. If you have a new medication, it has to go through the mill. It has to go through the trial phase 1, phase 2, then you go all the way. That's why the vaccine. To be honest, I'm thinking you should have said, we're surprised we don't have a vaccine. I thought we're so advanced. Okay, we can go to the moon and come back. We're going to the Mars and getting all. I thought we'd get a vaccine in like a month. No. All the artificial intelligence, we can't do anything. So we're back to rudimentary immunology. Okay? And that is the shocker, because I thought we're so advanced in healthcare that, a vaccine for this virus, so it's like no-brainer. We just get the computers, knock things out, within a short period will come out something. No. So we had to go through, the coronavirus has really taught us that we're nobody. But you still, yes.
It's belittled everybody, and not belittled, but it's humbled everyone.
Yes.
Humbled everybody. And if you don't keep a humble heart, you won't be learning, because there's always something new about it every single day. And exactly. So I don't have any further questions, except a lot of people applauding you. And then Dr. Indiago Abu said, I agree with the suggestion of research assistant to assist with clinical teams. And there's some familiar names here, so I'll just mention them. Dr. Joseph Akama is the son of our beloved Josie, who passed away recently. And he's also an infectious disease specialist, so we're really glad that he joined us. And there are other names that Dr. Ifwanyeni, the president-elect of GPSF, was also joined us. Dr. Palu joined us, and many names. Today we had quite a high attendance with over 140 people joining. So we really appreciate the time. And so I'm going to see if people have other questions for us.
Or contribution, or any contributions, Dr. Palu.
Okay, Dr. Obiri, Nicholas was saying that his question on the mishmash was related to how we are divided hemispherically on therapies. I'm assuming he's talking about how the northern hemisphere has, set the bar, and
right.
Dr. Obiri, you can respond, to it in typing. I'm sure that's what you mean.
Yes.
For me, my feeling was, a lot of the therapies we're using, we started using them because the Chinese and other people said it worked. I mean, I don't know if as Ghanaians, we would have thought of using hydroxychloroquine for COVID because it's really non-conventional. So if they used it and they've come out with data that said, but I mean, it's such a controversial area, I want to just stay away so I don't get black painted. Dr. Kofi Apia, one of the nephrologists, said, excellent presentation, Dr. Akama. And so I think—
he's my classmate.
Oh, he was your classmate.
Kofi, yes.
So Kofi is giving you a shout out.
Thank you, Kofi. Thank you.
Yeah, okay. Well, I think we'll bring our conversation to a close. It's 11:30. You've been very generous. And I think 5 hours is a small— I think you spent at least 8 to 10 hours preparing this, maybe every day, digging out a lot of information. And so we're very, very thankful that you prepared the best meal for us. And we really are full. It tasted good. And so we're very thankful. There's one more question. Grace Adolfo said, it's just exciting to see Ghanaians coming together in such a forum. Yes, and thank you, Grace, and expect to see more of it because we really are one. Some of us went to the same medical schools. We're separated by the ocean, but we're close in heart, and GPSF in particular stands for our vision, and our mission is to bridge Ghanaian and US-based physicians and around the country and the world actually to make sure that Ghana continues to get the best healthcare. And so that's our mission. That's what we try to do on a daily basis. So you'll see more Ghanaian physicians presenting, and Dr. Akama has been an excellent example and a shining example of that. So we really appreciate it. And for those of you who live in the US, if you're a physician and you're not part of our organization, we want to encourage you to join us. When you log off of this forum, the website will direct you to ghanaphysicians.org. Please log on and join to be a member. It's only $250 for the whole year for all these weekly webinars you're going to be getting. And so we thank you so much for joining us. And Dr. Akama, if you have some closing words, you can say
thank you very much. Thank you. And thanks to congratulations to the president-elect and yourself. You're an executive, isn't it?
Yes, yes.
Well done, Paul. Thank you very much for organizing it. And
Paul takes the credit for digging out Dr. Akama, because I had some cardiologists I was relying on and they all turned me down at the last minute. And Paul's idea was, let's get a Ghanaian physician to give his perspective. I said, okay, you go work on it. And so we want to thank Paul for the work he put into getting Dr. Akama, and he shone like a star. So Paul, you have any closing words?
No, it's okay. So I also have to give on the credit to my classmates who, since we are giving credit to everybody, my classmates actually ended up suggesting Dr. Akama, and so I reached out. Thanks.
Good. So it goes back to the last person, Grace, who said collaboration. So everybody depended on, so we're all a close-knit world, and it's a beautiful world when we come together. So on this note, have a wonderful week. Next week, we may be looking at obstetrical management in COVID-19 and a few other things. So please join us. It'll be a good time again. And thank you so much. We're very, very grateful.
Thank you.
Yeah.
Bye-bye.
Thank you, Benjamin.
Talk again.
Thank you.
Bye-bye.
Bye.